that happens when
Good morning, everyone. Welcome to our show, the Love Thy Neighbor show this morning. We are happy to bring to you today our showcase around community partnership and how synergy can improve the perinatal care experience. I'm your host, Dr. Kendra Flores-Carter, and I would love to introduce our amazing panel here for you all. So let's get started with Dr. Roloff.
Hi, everybody. And hi, friends. It's really fun to be here today. It's a different experience. My name is Christy Roloff. I am a maternal fetal medicine physician. I primarily work at Arrowhead Regional Medical Center, but I also work with the fabulous Dr. Kendra Flores-Carter, who also needs to introduce herself in a moment. And we co-direct the NAEBOR Clinic Project. NAEBOR stands for Neighborly, Adaptable, Equitable Care for Black Obstetrics Patients with Respect. And it's a program we launched about 3 years ago now, where we care for our Black birthing people in a cohesive manner with a social worker, with embedded folks, community health workers in the office, so we can provide wraparound services in the actual medical care space. So it's exciting to be here and talk about this project and how we've partnered with the others on our panel to create synergy between medical care and our community-based organizations that are also doing exceptional work in this space.
Absolutely. Well, lovely to meet you, Dr. Roloff. And yes, I love working with you. It's great. All right. Now we have Dr. McIntosh, who will introduce herself.
Hello, my name is Dr. Erica McIntosh. I'm a licensed clinical social worker. I also have my doctorate in social work, and with an emphasis on health equity. I got a whole degree on teaching people how to treat women and men of color. And I work in the NAEBOR clinic as a social worker and do co-research with Dr. Roloff and Dr. Flores-Carter. It has been an exciting journey, and I'm also an assistant professor at California Baptist University, and I own a private practice on apologetic therapy and consulting.
Okay. Thank you for introducing yourself. All right. Now we have Miss Monique Amos.
Good morning. I'm so honored to be amongst this panel this morning. My name is Monique Amos, as Dr. Kendra mentioned, and I am the Division Chief for the Community and Family Health Division here at the San Bernardino County Department of Public Health. I also serve as a local MCH director, and within the Community and Family Health Division, that includes all of the MCH programs, Black Infant Health, Perinatal Equity Initiative, California Home Visiting, Fetal Infant Mortality Review, SIDS program, and School Health, the LED program, and the Foster Youth Nursing program, as well as Women, Infants, and Children, and Nutrition and Wellness. So thank you for having me this morning.
Absolutely.
Just a little job.
Just a couple of things happening.
And then we have the lovely Miss Kanisha. Please go ahead and introduce yourself.
Hello, everyone. Happy to be sharing space with you all today. My name is Kamisha Neal. I serve as the program coordinator for the San Bernardino County Department of Public Health Black Infant Health Program. I am also a registered dietitian, a birth doula, and a lactation consultant. So very happy to be a part of this work and sharing space with you all today.
Absolutely. What an amazing panel of brilliant women here. I'm so excited to really get the conversation started. But first, let's kick off today's hot topics with a powerful headline from the Press Enterprise, which talks about how the Inland Empire providers are working to improve Black maternal health. And so the article highlights just how local providers are stepping up to address the alarming disparities in maternal health, especially in places like San Bernardino County, where the average life expectancy is up to 15 years lower than the state average. Very, very concerning. It's a reminder that health equity isn't just a national issue, it's also a local one, and it's happening right here in our own backyard. So I wanted to kind of get started with you, Dr. Roloff, to kind of ask you, in this article it mentioned that many Inland Empire zip codes show substantial healthcare need, right? How does the neighbor clinic use this data that we get from the state to guide the outreach and care strategies that we include for a neighbor clinic?
Sure, I think that's a great question. So the neighbor clinic opened first in Rialto City, which is in the Inland Empire. The Inland Empire, well, I should say that specifically San Bernardino County is the biggest county by square footage in the country. And so because of that, our zip codes have, kind of just sort of gaps when you look at it and you divide up the county of folks that are living maybe further from, points of access for medical care. And I think this disproportionately affects our Black and African American communities and our communities of color. So we first opened in the Rialto city, the city of Rialto. Our clinic is in the zip code that has the highest fertility rate. So where there are most people getting pregnant, that's where we opened our first clinic. And then we recognized that catchment area pulls in a lot of our Black birthing moms, but it doesn't reach everybody. And so we have a second site that opened in the Redlands area. And that was mostly to get into the population that's in San Bernardino City. And then now, even just this morning, we're talking about how do we get into our high desert area where we really know there's a need. And we do try to get out there to community events and promote our offices. And we do try to promote telehealth as a viable adjunct to, get people access to the care they need and timely. Unfortunately, we're finding that people would rather meet us in person than do telehealth, but we're working that out, and we're strategizing, and we're working with our partners at DPH to think about hub and spoke models, space, and how to collaborate to reach our sort of areas that have the most need and the least access. And I think Monique could probably speak to that same kind of point. How do we work together to make these zip codes accessible to the care they need?
Yes, Dr. Roloff, thank you. So what we do know is that we do track our losses in San Bernardino County by region. And so we know specifically for the Valley region versus the Low Desert region, because like Dr. Roloff said, our county is the largest geographically. And so there's lots of territory to cover. And what we know is, right, that some of our greatest disparities are in our high desert region. And so how do we get to folks in those areas when we know that getting care means coming almost 2 hours, and many of our patients don't have transportation. They may need help with childcare. So how do we really meet our families where they are? And I think working with the doctors that are on the panel today with public health has really demonstrated the need to integrate and break down silos in terms of bringing that clinical care and then integrating that with community-based programs so that we can meet our patients exactly where they are, because we're all serving the same community. We know that they are delivering at our county hospital many times, and so we want to make sure that the same folks that are coming to deliver at our county hospital and then they're coming through our county programs, whether that's Black Infant Health or our WIC program, that we're making sure that the entry points are seamless, that we're an extension of each other's teams. And I think we've been able to do that in partnership with Dr. Roloff, Dr. Kendra, and Dr. Erica. So really glad that I think we have been able to do something great in San Bernardino County and really show what the model should look like for what it looks like to really, truly, intentionally break down silos and be in partnership on a regular basis to really bring the care to the community that it needs.
Nice. I think that's wonderful to hear, you working together to really fill those gaps. Dr. McIntosh, I understand that mental health is also an issue from reading this article, right? Mental health support is often overlooked in communities facing chronic stress and poverty. And we know a lot of our clients and patients, they come from low socioeconomic background, right? How do you help patients navigate the emotional toll of pregnancy in areas with such stark disparities?
Well, I'm glad that you asked, Dr. Kendra. So a lot of what we look at, it's not just pregnancy. So there are times quite frequently when clients come in, and I view them as my clients and my patient, right? Because it is a partnership in identifying that they may have mental health challenges, but as a result of these mental health challenges, they may not always want to seek assistance or support because they're also experiencing homelessness. They're also experiencing financial deficits. They're also experiencing where they're trying to figure out how am I going to be able to keep the children I already have. They're also experiencing where they may not have any supportive systems within their own home environment. As a result of this, part of that is making sure that we don't, that as NAEBOR, the social worker, who's myself as well as another colleague, I'm going to give a shine to her too, to Dr. Amoya Dunn, that we also ensure that we walk with them through their journey. And some of that looks like doing their assessment. Some of that looks like doing therapy with them at the NAEBOR clinic. It also looks like bridging and walking with them in supportive services.
For example, I assisted a client even yesterday that was experiencing challenges with getting actual response to utility assistance because I connected her. What was unique with this is that in the space of trying to be able to provide support to her, self-determination, she was working on it on her own, and she kept running into roadblock after roadblock after roadblock. And she said, Dr. Mack, they aren't hearing me. Part of the NAEBOR clinic, what we do is we'll partner and walk with them. It's not just handing them things to support them. It's actually taking the time to support them in that process. And so I spent the next 35, 40 minutes calling one organization that said, yes, she missed the cutoff. I said, well, this is interesting because we've tried this now 3 different times. There has to be something better. They gave me another supportive agency to expedite the process. Now, had she done this on her own, she continuously would have been in that same loop. Now, on the flip side of things, and so we saw a wonderful resolution there. Now, on the flip side of things, when we look at the mental health aspect of it, while I appreciate, because Dr. Roloff notes, absolutely, when it comes to the physical health, the clients definitely want to come in the office. What I found unique with the individuals with mental health, though, they want their very first visit maybe in the office, and then they want to be able to do it from home. So telehealth has been a very beautiful and impactful way of being able to promote change. Partly because if you think about it, these same clients that look and work and navigate with different stressors, such as transportation, childcare. If you go to most mental health facilities, they will tell you that you have to be there by yourself. You have to make sure that you come in a timely manner and all of these different things. And what happens when you have a 3-year-old that you don't have childcare for and that still needs you to be mommy? So your mental health declines because you're going to take your priority to your child. Telehealth makes sure that we remove the barrier of access and gives the clients back the agency to say, something, my baby's going to be here, and that is fine. Because ultimately what we're trying to reduce and improve is making sure that there's no wrong door to care and no wrong door to support. And even if they don't want to speak with me, then I bridge them to connect them to a supportive service in the community.
Mm-hmm. Absolutely. I love that. I love that so much because it gives the patients the opportunity to not only get the OB care, but also that mental health piece, right? And so I think that that's really, really vital, and it's really, really important when we're offering perinatal care, because most moms, when they just have a baby, they're not thinking about, I have to go to a clinic for my depression. But if they can actually be at home in their comfort and talk to someone and process through, I think that makes a lot more sense to a lot of moms.
Absolutely. It kind of, if you think about it, person doesn't know they're drowning till they're actually trying to struggle to keep afloat, right?
Yeah.
And some of that's also the education and what does depression look like? Mm-hmm. What does it look like when you're still pregnant, and what does it look like postpartum? We actually go through reviews and supports for that, and it makes a difference because not only do we tell them, but we also, if they're with the birthing individual's partner, give them that education too, because They may not see it in that moment, but the partner does. And now you have a wraparound approach to being able to support this client.
Yeah, absolutely.
And I just want to interject too for Kanisha, maybe you can speak to this too, because I think this is where we've partnered with our programs like Black Infant Health.
Yeah.
So that these ideas and this education, comes together and it's reiterated.
Yeah.
So I don't know if you can speak to a little bit about what Black Infant Health does to support these patients in that, perinatal mental depression space.
That's actually, Dr. Roloff, exactly where I was going. I was definitely going
steal
there
your
next.
thunder?
No, not even that. No.
The synergy,
That's
right?
exactly where I was going next.
Synergy.
So the article, wrapping up our hot topics, the article also talked about community outreach and disease self-management, right? Classes. And I know that Black Infant Health is a really huge partner for us. Actually, all of our patients get referred to the Black Infant Health program. Like, that's off the bat, right? So how does Department of Public Health, Black Infant Health, expanding these efforts to really include maternal education and support Black families? Yeah.
Absolutely. So with the Black Infant Health Program, we have what's called an evidence-informed, empowerment-based group model. And so primarily our participants, we want them to go through this group model where they're receiving a curriculum-based education on things like labor and delivery, coping with stress, like Dr. McIntosh was talking about stressors. And so there's different points throughout the curriculum that will address didactic learning with those types of stressors that may pop up in their life. But in tandem with that, right, they're also receiving support from peers, right? So it's a little mix of education, a mix of peer support in that environment, and they're receiving outside of the group environment tandem support through targeted case management. And so they are assigned essentially a caseworker who journeys alongside them on their postpartum and their prenatal experience. And so they're individualizing that care for that family. And so we may have a family where housing is the thing, right? And so they don't want to hear about kick counts, which is very important. They don't want to hear about blood pressure and diabetes and all of those things, because the top of that pyramid for them is, how are we going to address this housing? I don't have food to eat. My bills aren't paid. My lights aren't on, right? And so the case manager can be very targeted in that way of addressing what that primary concern is, and then still providing that wraparound support, because the kick counts are very important. The blood pressure is very important. And then we know that some families, again, with stressors and things that are happening in their life, they may be working 2 and 3 jobs to make ends meet. And so they may not be able to come to the group sessions that we have during the week. And so the program model is flexible in the way to where they can just receive 100% case management support. And so that case management support is very flexible. So it could be in person. And so we have participants who may be struggling with things like intimate partner violence. And so being able to do a phone appointment at home is not the safest space for them to be open and vulnerable about what their needs are. And so them having the option to come to this safe haven, to receive that education, to receive that support, is going to be vital in the lives of the participants that we serve. From there, we are definitely partnering with lovely and powerful entities such as the NAEBOR Clinic to provide those referrals and support so that they can receive healthcare outside of BIH, right? Because on the continuum of disparity reduction work, it's just not one entity. We all have to be a part of the solution. And so they are receiving that culturally aware support and respect through NAEBOR Clinic. We partner with other public health advocates and community-based organizations. So we have Oral Health come down, Smile SBC doing education on the importance of oral health. We have Marcel Wellness coming down and talking to the families about the importance of supporting fatherhood and their role in the journey of parenthood and health and wellness. And so we partner with other organizations from that perspective. And then we also have, through the Family Health Services section, our division, we have community health workers. So every single woman that is enrolled in our program, they get connected with the community health worker who is enhancing the support that they receive at BIH. And so, we've had instances where those community health workers have been able to secure immediate food relief for these families that are experiencing food insecurity. Because we know that programs like WIC are wonderful in filling gaps, but they're supplemental programs. And so we have to be able to connect the pieces to give them the fulfillment that they need. And then from there, we are partnering with Perinatal Equity Initiative, which is our sister program, who is providing further support, right? And so they contract with partners with Sankofa Birth Workers Collective, and so the families receive access to doula support. They also partner with fatherhood programs, so then the dads, the same support that the moms are receiving at BIH, they're getting it through the fatherhood programs in the high and the low desert regions. And then our Perinatal Equity Initiative just recently launched a maternal mental health support system as well. And so now they're receiving that level of support. And so it's just about addressing all of those stressors that Dr. McIntosh talked about, and having connections with those in the community that can be a village truly for the families.
Absolutely. That's wonderful. That wraparound care that Black Infant Health comes in to provide. I think it's so vital to, our moms thriving, right? So, yeah.
And I just want to say this is so cool because, like, you're talking about all of these organizations, right? That NAEBOR now and the medical care space. I think this is what's so unique. It's so unusual to have like a physician's in obstetrics office come in and synergize with all of the same organizations, the fathering program, what else? The oral care, Children's Health Network and the cribs. You guys are providing the cribs. We're providing the cribs, and the patients are getting this support in like this like cohesive front where it's not you go here, you go there, and you guys are taking care of the social determinants while the care providers doing the physical and the medical, but it's not separate. It's like this, right?
Absolutely.
And that's really the point of this panel today is to, show how the clinic can be part of the community and part of the solution.
Yeah.
I just think it's so unique. It's giving me chills. It's so exciting.
Absolutely. And we could kind of further go into the fact that our other social worker, Moya Dunn, recently did that fair, right, in the parking lot where it was direct access to, all of our community-based partners. And so patients were able to literally have a one-on-one, a face-to-face with a lot of these partners right there at the clinic setting. And so, again, another way to help them bridge those gaps where they might not be able to make that phone call and be on the phone call, but they can go and get direct access to organization that could really help them. So, yes. All right. Well, wonderful, wonderful hot topic, ladies. Thank you so much. All right. So moving on from our hot topics now onto our panel discussion. And first, we'd like to share our NAEBOR video.
So what the NAEBOR clinic is it's actually a race congruent clinic that actually provides affirmative and supportive care and assistance to Black pregnant women as they are entering into healthcare.
NAEBOR Clinic has been a staple due to the fact that we've seen in California where our Black moms, when going through such a beautiful experience of having a baby, that oftentimes they do suffer 3, almost 4 times the risk of mortality in pregnancy.
So the NAEBOR program provides antenatal care services, which are visits here in our office, and then we have standard postpartum care visits here at our office as well, which we can continue care for up to a year.
We take care of them from the moment they are identified as being pregnant, and we give prenatal care all the way through their 40th week.
We offer 3 models of care here at NAEBOR. One of them being the traditional, where they could come in and out for visits. The second one is telehealth, where they can do half virtual visits and then half in-person visits. And then we have the intensive one where, hey, we're seeing you as much as we need to see you because you fall in that category of being maybe a high-risk patient.
We look at not just one facet of the person, it's a holistic approach to care. So it looks at the medical needs, the social, as well as the mental health components of the supportive services for the NAEBOR clinic.
And we really want to make sure at this clinic that we're listening to the whole person so that we can be able to identify any risk that predisposes them to any adverse outcomes in their pregnancy. And we're trying to be able to mitigate that by offering different ways of prenatal care.
We have a staff that looks like them. When people have a certain comfort level because they are cared for by people that look like them, sometimes it's easier to care for them.
We're really trying to make sure that you leave here with better outcomes, whatever it is that might be. All right, so such a great program, that NAEBOR clinic. I really think that we're doing an amazing job, and we're probably one of its kind. I don't know if there's a lot of clinics out there. There might be some, but I think we're really setting the bar, definitely when it comes to innovation. And so we'll move a little bit into patient-centered care and looking more at clinical innovation. As you guys heard in the video, Black and African American women are 3 to 4 times more likely to die from a pregnancy-related cause, right, than any other race when compared to any other race, right? And that's definitely serious, and it's so significant. Why are we more likely to die 4 times, right? That's so much. These disparities are not always due to biology. They're rooted also in systemic inequities, right? And systemic inequities can include access to care, right? Access to resources, socioeconomic barriers, right? I think Dr. McIntosh mentioned earlier some barriers that moms might have to getting to the clinic, right? And so being able to reach that through telehealth is really helpful, right? And so I'm really trying to see what are some of the things that could come up that really pose as a barrier. It also includes provider bias, right? Today, we'll explore how the NAEBOR Clinic and San Bernardino County Department of Public Health are working together to change this reality, right? Let's get started with our first question. Dr. Roloff. Black women face a pregnancy-related mortality rate of 3.5 times higher than white women. How does the NAEBOR Clinic's model of adaptable cultural responsive care address this crisis?
So I think in an evidence-based way, we know, and we've talked about the wraparound services and provision of all of those things, but we also, in addition to bringing those bringing that synergy together in our clinics, everybody's cross-trained in provision of cultural humility in the clinic visits, as well as trained to promote cultural safety, from the front office through to the referral back office, even people that aren't having direct patient contact. We're all working together to bring ourselves into that space of allyship where we know it's important to promote that Black person, recognize the institutional damage racism has done to that population. And so I think we're just sensitive to it, sensitive to taking care of each other as well as our patients. We've also really adapted a model where we're trying, and it's a little challenging because we are trying to provide racial concordance, because we know, as you've told me, that Black moms want to have Black providers and Black MAs and see themselves reflected in their healthcare provision. And it's a little bit challenging because the Black and African American communities are underrepresented in healthcare professional training. So wherever possible, we try to provide congruent care, race congruent care. And we do pay it forward to those people and invest in them. And Destiny, one of our very first MAs that we had hired in the clinic, she was cross-trained as a community health worker and was doing the community health work in the office with our patients, and we invested in her, and now she's a supervisor and she's exceptional and we adore her. And so we look for those opportunities to really promote and elevate our Black and African American health professionals, so that they stay with us, they stay loyal to our clinic, and they stay in that area where they're doing the good work. So I think that's been really, really positive.
Yeah, absolutely. That's amazing. It's amazing to hear that. I do think that having culturally responsive trained providers can really help to improve the type of care that patient receives. And I could speak for my story when I, my oldest is going to be 18 next year, but I remember the very first time that I went into the clinic and beginning stages of labor, and they sent me home, and I was in so much pain. And I'm like, oh, I remember hearing I think one of the nurse say, well, you're only 1.5 centimeters, so go home and come back in 24 hours. And that was it, right? And so it was like, but this is my first pregnancy. I don't really understand what's happening to my body. It would have been a great opportunity for someone who was maybe responsive to what I was going through to kind of explain, okay, over the next 24 hours, this is what you're going to be experiencing. But that was not given to me. So it was a little bit like, okay, I came back 24 hours later and I was, I guess, 4 centimeters. They wanted to send me home again. And my husband was like, no, she's not going home. She's in a lot of pain, and I have had to deal with her for 24 hours. And so, that's, and he was like, I would like to speak to the doctor. And I think that's where we get into advocacy, right? The importance of advocacy, having someone who can advocate for us when we're going in labor, and that's where maybe the fatherhood or the partner support comes in. So I definitely love that you shared that, Dr. Roloff, the fact that there's cultural responsiveness and really engaging in that. I want to go a little bit more, I guess, into mental health with you, Dr. McIntosh. And really what we do know is that maternal health challenges disproportionately affect Black women, right? Yet they are less likely to receive treatment. How does your role as a clinical social worker help bridge this gap?
So I love that you asked that question. So it reminds me of something, and your experience also kind of echoes what I'm about to say. I do believe it was Maya Angelou that says that we may not remember what, and I could be paraphrasing here. I'm not perfect, okay? We may not remember what the person did. We may not remember what the person said, but we always remember the way they made us feel. Mm-hmm. So if we really think about how we make a client feel, some of this starts with the education. Some of this starts with making sure that this very second that they walk into care, that they understand that, you know what, I see you, I hear you. And even in this space where you might be feeling your lowest, that I'm going to walk with you. And there's no wrong door to being able to get that. It's making sure that that their experiences aren't minimized, whether it's with myself or with any of the other providers. I'm not going to say that we always get it perfect, because that's the reality is we all have this wonderful thing called the human condition, get into it. But because we have that, we know that we're always going to make mistakes, but it's owning those mistakes and honoring the space that they're in to make sure that they feel validated, seen, heard, and that we can actually work on the things that they want to work on, not the things they think that I may want to work on, but what they actually are identifying as a challenge. Mm-hmm. And more importantly, sometimes it's echoing and reinforcing that, you know what, I may have not have felt so great in this moment. How can I now be your advocate? Mm-hmm. Mm-hmm. It's making sure that bridging looks like I may need to make that call with you. Mm-hmm. Bridging looks like I'm just going to make space right now, and whatever is going on in this moment, we're going to work on it together. Yeah. And I think that when you start to remove the challenges with having to also code switch. Talk the way you're going to talk, because if you have to try to validate how you want to get something said so that you're sounding PC, not meaning myself, meaning my clients, that they don't have to try to figure out, well, am I going to make this sound pretty? No, as I shared with them, I'm like, share with me the real tea, and they chuckled just like you did. And the next thing you know, I'm reducing some of those challenges. The cultural responsiveness when it comes to care is paramount to an individual wanting to actually continue care. And if the second that we stop actually leaning into, I'm the provider, you're the client, more, I'm a mother, and even if it wasn't a mother, I'm a woman, I'm a human. We have individuals that may be on the continuum, and giving them the space to say, you know what, whatever you're feeling in this moment is valid, it's true, and I'm going to work with you. That's how we end up bridging those gaps.
Absolutely. Thank you for sharing that. Monique, I wanted to ask you this question because I also know that the Department of Public Health does the yearly Perinatal Equity Summit. So I'm curious to know how you guys are really addressing the maternal mental health issue within our county, and also how you're filling the gaps as well by really having this yearly summit for providers, for community members.
Oh, absolutely, Dr. Kendra. So we actually partner with Riverside County to do the Perinatal Equity Summit, and that has been tremendous because for those who are in our area, they know that our borders, you never know what county you're in, really, based on our borders. And we're neighboring counties, and we do, based on the population that we serve, right, they're moving across the border all of the time. And I hate to even say borders because it's invisible. We don't even know what that looks like most of the time. And so it's been great to be able to partner and bring all together the providers in the area. And that's what the Perinatal Equity Summit has allowed us to do. I think not only has it allowed us to bring together the community of providers, and when I say providers, I mean that in mass, right? So not just medical providers, but doulas, other birth workers such as midwives, community health workers, public health space, other community-based programs. So and I think that that's what it has allowed us to do, is to create community, because so much of what we do is breaking down the silos, because folks don't know that we're not connected, right? They assume that we know each other. They assume that we work together. And so when we can make that actually happen for them, I think that's what Perinatal Equity Initiative has allowed us to do. It's also allowed us to kind of sound the alarm, right, on the disparities. And that's exactly what it was designed to do. It was designed to create some of those supplemental supports, but also primarily sounding the alarm on the disparities that Black women face, and Black families. Let's just, say it what it is, Black families, right? Yeah. Because we're talking about mom, we're also talking about baby, we're talking about dad, and we're living in a space where families look different today, right? Mm-hmm. Like, so maybe you're partnered and you're not married. Maybe you intentionally decided to co-parent. Maybe you're not in a relationship. Whatever that means, that's still a family unit, and we're supporting that family unit. And so that's what Perinatal Equity Summit, Perinatal Equity Initiative Summit has allowed us to do. But I wanted to say, to piggyback on what Dr. McIntosh said, is that building trust is what we know is important with the, to eradicate the disparities, because there's been so much harm that has been done to our community. And so building trust, and so much, when you shared your story, Dr. Kendra, I thought about, the fact that I did have a Black physician for my first 2 pregnancies, and how much of a difference it made. Not that there was a sense of trust already, but being able to have conversations that just 2 Black girls can have, that other, that I couldn't have with a different provider. It definitely created a space where I trusted her to ask questions. I trusted her that some days it would be my prenatal appointment, and we may not talk about anything, but girl, who did your hair this week? And that makes a difference. And but in terms of trust, I think, what our panel discussion today is about building those relationships of trust with each other, so that that the folks that we serve can trust us and know that, yeah, you know what, I do know Dr. Roloff, and you know what, we'll make sure that whatever it is that you need, you get that to support your family, to support this pregnancy. And so that's what I think that the Perinatal Equity Initiative has done more globally, is allowed us to come together as community so that we do know who to call, because that makes a difference. Because just like you were mentioning about, trying to get housing support, we don't have 28 days to find someone a place to stay, right? So we need to know the direction to call. We need to know who to call. We need to know what the process is, and we need to be able to expedite it so that, because we want to encourage that not only are they getting housing, but we're preventing another referral to CFS. All of these things go together, and that was what PEI has allowed us to do, and that is to create community with each other so that we can support our community together.
I just want to say too, it's taught, I think, providers, and to your point, whatever kind of birth worker provider you are, to listen, right?
Yes.
So that if you don't have a Black or African American physician obstetrician, maybe you're stuck with me, but I've been taught to listen. I know, but I don't mean stuff. You know what I mean.
I'm saying that with love,
get it.
that you are so
But
much an
you're
ally.
all of us. It's regardless. Every person you're gonna meet in the birth experience is listening, is hearing you, knows that if you say, "But I'm having too much pain to go home," I hear you. We're gonna talk about how that shakes down, right? And I think the Perinatal Equity Summit teaches us that, right? Teaches us to hear each other and to lose the idea that it's about our skin color or our ethnicity.
Can I just add to that, Dr. Roloff? Because when you said that, it made me think about, we have had stuff, and listen, I think we have built so much trust with the people that serve in our community. And I remember a speaker that we had, and people pulled me to the side, "Girl, he ain't one of us. What's happening?" And the reality is that in that space, it's safe. In that space, we learn, we were open to learn, and then when we get down to the bottom of it, we're like, you know what? We're all here for the same reason. We all want to do good for this population that we're serving, because we know also the bigger thing is not just we want to improve outcomes for Black women. We know when we do that, it also benefits the rest of the maternal population. And so I think you're right. That's exactly what it's done. It has allowed us to be in space together and say, you know what? I may not know this person, but I know that they're here for the right reasons, and we're going to learn together.
Absolutely.
Yeah, and I think that's one of the things that we definitely try to do really well with Neighbor Clinic is making sure, because in all honesty, we don't have enough Black providers.
No.
We just don't, right? And trust me, we have looked, to try and find them and hire them, but it's just, the people who do apply, and we have to also look at our demographic within the county, within the IE.
Right.
Our demographic is majority Hispanic, right? And so the majority of people who we will see is going to be Hispanic. So the goal is making sure they're trained to be culturally responsive, and not only trained, but also I think we have to get out of this idea of training once. We have ongoing training.
Yes.
We make it an effort to make sure, okay, it's time for a new training to go, and just so that we can reinforce this is how we want you to approach our patient. So it's really, really important, and it's valuable that it doesn't matter from the moment you walk into the front office, you need to make sure that patients have a safe space with you in that one-on-one, right? Communication is definitely key, and how you approach the patient is important.
And if I can interject here, Dr. Flores Carter, what I will say is this, and I'm going to push back with love. You've heard me say this before, so with love, I'm going to push back. It's like, just, if they got to get me. There's a reason why, if there's a disproportionality within the provider sector for Black providers, we also need to make sure that our counterparts that are not Black and brown also are equitably trained to be supportive and responsive. And I would say that this woman here is what's called an accomplice. Most people think we're talking about jail. No, allyship can be sometimes performative, where they talk it, but they don't do it. The accomplice jumps in and says, you know something, I'm not only going to talk the talk, I'm going to walk the walk, and I'm going to show other providers how to do it, so that, you know something, they may not take it from myself the same way that they take, or for Dr. Flores Carter, or for anyone else that's sitting on this panel, the same way that they may take it from you. And that's why we see that bias is still a thing. And so sometimes it takes not just people of color, but also that we have to have these partnerships and alliances. And we see a lot of overlap, because I refer to Black Infant Health, I refer to Sankofa, I refer to all of these different agencies and organizations as well. And it takes all of us to change this issue. If we want to make sure that there is support and culturally responsive and culturally congruent care. You know, there's nothing like seeing another person that sits across looking like you. But if there's not someone who is available to do that, you need to make sure, darn sure, that the person that is going to treat you the same way, the same support, that same level of compassion, hearing, and making sure that they validate everything that's going through. And I think that you've done a great job of that, and that in the training of this, because you're at the clinic, at the larger hospital, that they're starting to see some of those changes.
Oh yeah, and they are.
Absolutely.
And we model it, and we train it, and it's not, for me, about treating everybody the same. It's about elevating the Black and African American community. It's about learning from your experiences so that we implement and we get better together. Because it has to change. We can't have Black and African American communities or any communities of color marginalized anymore. It's not okay. It's time. It's time.
Absolutely.
to fix this.
What you've done, though, Dr. Roloff, is you continue to keep yourself open to learning. And your posture makes a huge difference in terms of being open to learning. And so we can always kind of like strategize together. Like, okay, so because in this work, what's so important is that we're continuing to be responsive to what the community tells us, that we're letting the community tell us and drive the solutions, not for us to think that this is what needs to happen. And that's what you model, Dr. Roloff. And so I just want to kind of piggyback on what Dr. McIntosh said, is that if we could just continue, and I think that's what PEI has allowed us to do too, right? Is to have folks say, let me think about it. Let me be open to maybe thinking of a different way.
Absolutely. And stop making assumptions and stereotype drive the type of care that we provide right, to people. This is a segue into our system change and community engagement portion. And I really wanted to highlight Monique and Kanisha's voice with this. Because I know that you guys are doing some great things within the Department of Public Health. We know that the Prenatal Equity Initiative and Black Infant Health programs are vital in addressing systemic disparities. With Black infant health in San Bernardino County dying at nearly twice the rate of white infants, how are these programs driving change?
That's a powerful question. Something, Monique, that you just said, it spoke to me because it resonates with some of the conversations that we've been having with participants. And it's the elevation of their voice, right? The answers to any issue in the community is always going to lie within the community themselves, right? And so in the Black infant health space, the participants can share that feedback in a number of ways, right? And so it can happen during the group sessions organically. And so, like, for example, we heard from one of the participants, right, from the conversation about maternal mental health. And there's this overwhelming fear of being honest when answering those screening questions because of the fear of, how am I going to be perceived? How am I going to be labeled? Is there going to be a referral made to CPS because I'm honest about the things that I'm struggling with? And the inclination is to be like, well, the system doesn't work that way, right? Like the system is here to provide support for you. But when we acknowledge like the systemic barriers that these families are experiencing, whether it's in healthcare environments, whether it's over policing of communities, it's the fear is there, right? And so how do we take that feedback of, I don't even want to answer the questions on this form because I don't know what's going to happen if I'm honest about it. And taking that feedback into the spaces where we're connecting with one another from a strategic planning standpoint, right? So now we have our community advisory boards, we have our community action team. So how are we taking that feedback that we're getting from participants? Like, great, we have postpartum depression screenings, we have Edinburghs, we have PUHQ9s, and all of these things. But they're not going to answer honestly. They're going to give you the answer that they think that you want to hear so that they can get out of this session. So how do we acknowledge this very real fear that they have about being judged, and how do we change systems, right? There's an issue with the system. And so I would say that that's one of the ways that we're driving change, is by taking the voice of the participant and using it as a launching place to guide discussions when we're having these CAB meetings and these CAP meetings. Another perspective is even with that feedback and using it from like a staff training and development standpoint. Because even when you have folks that are culturally representative of the population, training still has to take place, right? Because there are still cultural and social differences. And like you can see it pop up like in breastfeeding, for example, right? That's one of my passions and my background. And so some people are like all for breastfeeding when it's a very tiny newborn, but once that baby is like 3 months and plus, they're like, this kid is too big to be breastfeeding. You have a 2-year-old and you're still breastfeeding? Oh no. Or you need to do that behind closed doors, right? And so there's still very real differences in perspectives, cultural, social beliefs, beliefs that are different throughout generations, right? And so there are still walls that have to come down, even when you have staff that are culturally congruent or representative of the population. And so if a participant is coming to the table and saying, hey, sis, because I can call you sis, I didn't like the way that this came up, right? This is how I'm feeling. That we respond to that very quickly, right? And so it's just really allowing the voice of the participant to be elevated in the space to drive, whether it's strategic planning at a system level, staff professional development and accountability, and educational materials. We are centering the voice of the participant.
Monique, definitely want to hear from you on that specific question as well.
For sure. Thank you, Dr. Kendra. And, I think that what we really are trying to do within our division and then as we work with our community partners is move past collaboration to collective impact, because that looks different, right? It's an intention to work together and to really understand that we're serving all of the same individuals. It's not like ARMC is serving this one group and then Black Infant Health is serving this one group and like our California Home Visiting Program is serving this group. No, we're serving the same individuals. So the more that we're talking to each other, that's the better that we can serve that individual. Well, the better that we know. If I use Kanisha for an example, the better that I know what happened when she was visited by the home visitor, and what that assessment looked like and really what her needs are. I don't ask her the same questions again. I honor her time. I can make sure that she's getting access to the care that she needs. But then I think one thing that we also have been trying to make sure is that our participant, because there is a sense of trust, right? When you're working with someone with a community-based partner, there may be a different sense of trust because you spend more time with them. But reminding those that we're working with how important it is to be interfacing with their medical provider, right? Like if you can't get to your prenatal appointment, tell us how we can help you make sure that you get there. And then let's not stop there. Let's make sure the baby is already ready to see the pediatrician and is connected to a pediatrician. Mom, let's make sure you're still getting your well checks after you deliver. And let's make sure that we're continuing on that continuum of care, because it's about the life course. It's not about this one moment in time. And so so the more that we can kind of drive what we're doing through this sensitive period, and it improves the outcomes over the life course. And not just for mom, remembering that this is a representation of family. So that could mean grandma that's still, that's living in the home, or there may be an older cousin, baby, all of the things. The education that we're talking about means, particularly with, communities, and I think what Kanisha and Dr. McIntosh were hitting on is that remembering that we're not a monolith, right? And so what's happening, even in San Bernardino County, there's a culture here in San Bernardino that looks a little bit different than it does in the high desert. And so when we're having those conversations, being mindful that everyone in that family needs to get the same education, because there could be some cultural differences that say, just like Kanisha said, maybe that wasn't what was part of, because there is this time that, remember, there was harm in breastfeeding. Black moms were made to breastfeed other babies, and so there was harm, and there's still that unpacking of the trauma that is still happening when we're in this care space, and the care space is big, right? It's not just the medical office, it's not just when you're time in Black infant health, but through that continuum of care. And so doing that in a way that, again, we're moving past collaboration, letting still the data drive our decisions, monitoring the data as a tool and not to harm, right? But as a tool so that we can stay on top of are we making an impact? Are we really making that systems change that will allow us to kind of recreate and rebuild the system of care so that like Dr. Roloff said, we can stop the same narrative. These things have been persistent. And I think what I love is that we're at a time here in San Bernardino County where we're really serious about wanting to impact change.
I want to talk a little bit about the fetal infant mortality review team. I know I have been a part of going to some of the meetings and kind of being on that advisory for many, many years. I know Dr. Roloff is also a part of that. I would like to know, what role does the FEMR play in shaping policy and improving care within these systems, especially as it relates to maternal mortality?
That's a great question, because I think often folks don't understand how that is a touch point along this whole system of care, right? And so while it's not, if it's your first meeting and you're listening to often what are very hard cases to listen to, you may not understand really why that is a spoke in the wheel of what we're doing. But what it allows us to do, because we do know that the disparities are highest in certain regions of our county, but particularly for the African American population, we have a priority selection of cases that focuses on the Black and African American population, and it allows us, again, to let the data drive what we're doing. It allows us to inform, but the beauty of FEMR, and I know we're using an acronym, so I'll say it out all the way so that folks know what that means, but for the Fetal and Infant Mortality Review, FEMR, not only do we have great professionals like yourselves that join, and Kanisha joins, and it's a diverse group of individuals who are included in the care provision, but then we bring that voice of the community in, right? Let's look at, because often what we see is that it's not something happening with mom physically, right? It's mom couldn't get to prenatal care for whatever reason. Mom wasn't connected to insurance, or there's an IPV issue that's preventing her from getting to prenatal care. So many things. I'll often think of a case where we had a loss where there was IPV, there was excess mold in the home. There were so many things driving this poor outcome, and then like tying it to the mental health part. Most of our moms, 40% of the moms that for the cases that review are already experiencing depression before they go. So what it allows us to do is consider all of those socioeconomic factors that are influencing the pregnancy, things that could have been addressed during pregnancy, such as chronic disease. Like, what are those things that we need to do better through the system and recognize that if we improve the system of care, then it improves the outcomes for mom. And knowing that some of the system was just not designed for this population. And so, I'll just take this opportunity to give a little plug. If you're not already connected to our FEMA program or to our PEI, Black Infant Health PEI CAB, this is an opportunity for us to hear from the community. So a lay member of the community, you could just be a mom, you could be a sister of a mom. You don't have to necessarily be coming to listen to see what's happening with you per se or your family, but really being able to say, well, Monique, in Barstow, this is what's happening in Barstow. Yes. This is why I can't get to prenatal care. So while we have a sense of a pulse on there, on what's happening in the high desert, really hearing to say, not what we know to be the problem, but what does the community say is the solution? Like, what could help you during your care? So if you're not plugged in, make sure to get connected to one of our community action teams or our community advisory board, because that's the time that we get to work with you so that we can elevate the community's voice, so that we can drive decisions and drive our interventions based on what the community says it needs, and not for us to say, well, we know best because of whatever profession or lane we're in.
We are definitely keeping this going. I definitely want to thank you all for sharing some wonderful information. I want to wrap up our conversation by really asking about sustainability for programs like NAEBOR and, programs like Black Infant Health, and working together and consistently in this collective impact, like Monique mentioned. What continues, or what needs to be continued for us to really continue the great work that we're doing?
So, excellent question, and something that we think about a lot at the NAEBOR Clinic is how to keep this program alive, sparked, and energetic. And one thing I do need to say and bring up that I haven't yet is that this is operational under a grant, a very generous grant from First Five San Bernardino, who invests in the first 5 years of life, and we're very, very thankful that they recognize the first 5 years of life begin in the womb and begin with the family, not at birth. So that financial support, as well as the financial support from Dr. Valenzuela, has been incredible. And I worry that financial support is really critical, and I worry in these times what we're looking at going forward, how we're going to sustain. So I think financial investment from the state, from our federal government, is really going to be key to sustaining and keeping infant mortality rates down.
Yeah. I just want to piggyback on that. I think that, being mindful, I think it would be remiss not to address where we are kind of in this landscape. And I think that we are in a place today where folks don't understand what a community's health means, right? Community's health just means, which is, paramount to public health, and that is that something happening with me is going to affect you, and vice versa, right? So we have to protect the community's health overall. And so just being mindful that, your neighbor suffering does impact you. It does impact you. So when we're thinking of, when you're saying, why should this matter to me? I'm not birthing anymore. This is not my community. Someone struggling in your community does impact you financially, if that's the only impact that could impact you financially, but there's other ways that it finally impacts your entire community. I mean, we're talking about house values. That's something that's important to everyone, right? And so all of these things go together in your community, the way your taxes are paid, all of those things make a difference. And so just being mindful that while some programs have been under attack in this last calendar year, just thinking about understanding about how those cuts actually impact your community. if you can't see how it may impact you and you think, well, I don't have to worry about that, I have a good job, it does impact you. What happens in your community does finally impact you, and it will, even if you have not seen it yet, it will impact you. So if your concern is not making sure that your neighbor is okay, making sure that your community is okay should be important to you. So just being mindful that when we vote, and when we're voting for those who are supposed to have our best interests at heart, it does make a difference in terms of how federal funding comes to us, and being mindful that, again, even though you may not be a recipient of those benefits, if someone in your community loses those benefits, that's when it starts to impact you. And so you want the best for your community, and all of what we've been talking about, maternal health, loss, all of those things are an indicator of a community's health. And so we just want to be mindful that we need to have these programs continue, not just for the people that receive the services, but for the overall community's health.
Just to add that to that, sustainability for me is rooted in seed time and harvest, right? Every seed that we plant and that we water is going to bear fruit. And so we have such a revolution that happens when everyone in the community is working together. And so we see it even with the mothers in the Black Infant Health Program. And so, even before a fellow participant is getting connected to a transportation service, they're already starting a transportation line. Says, I have a vehicle, I can get you to your doctor's appointment, right? And so what that looks like at a larger level is empowering one another in the community to do whatever is within our sphere of influence to make change, right? And so one book, one pen, one teacher, right, can change someone's lived experience. And when we're all doing our part, it's going to bear that type of fruit. And so taking the lessons that we're learning in public health environments and healthcare environments and sowing that knowledge and those lessons into grassroots efforts, right? Because even if we learn from the past and civil rights movements, right? Making sure kids ate breakfast and had lunch and had meals, that didn't start with a federal or a state program. It started with the community recognizing a need and doing what they had to do to make sure everyone was taken care of. And so we can spark innovation from what's happening in the community and make sure everyone is well equipped to do the part that we can play in it. Yeah.
And finally, what I would say is with maintaining sustainability, it's also making sure that we are staying very person-centered. Every single individual that is touched, whether through the NAEBOR clinic, through Black Infant Health, through PEI initiative, that we ensure that they know that we exist.
Yes.
And that
Yes, absolutely.
and I know that sounds like very like a minute thing, but it really is very impactful. I am starting to see some of those same things with seeds being sown, with former clients referring new clients to NAEBOR, seeing individuals that came through Black Infant Health that actually said, I was in here and I met now she's my good sis.
Yes.
And she told me that she's seeing you. And she said, do you know this person? I know I couldn't confirm or deny because I'm, HIPAA. But it was so empowering and enriching to know that they're talking and having these conversations. So some of this also is making sure that the community knows and that at an individual level that we don't give up. Because if we continue, because even in this political climate right now, we are having challenges that make it seem very weighty to still want to engage. That knowing that, we're still here, we're still going to do this. We're going to find different ways to make this affordable and sustainable and replicable, hopefully replicable. But more importantly, that they know I can still connect my best friend. I can still connect my sister. I can still connect, fill in the blank here, but also that they see that representation matters, that they had an amazing experience, and in their amazing experience that another Black birthing individual can have that same experience too.
Yeah, absolutely. Thank you, guys. Today's discussion definitely illuminated the power of innovation, empathy, and community partnership, right? And how these partnership is transforming Black maternal health. The Neighbor Clinic and the Department of Public Health programs are not just responding to this crisis, this maternal health crisis, but they're building a synergetic future, right? Where Black mothers and babies are thriving. Let's continue to advocate for birth, equity, and justice, right? As we all have discussed today. Thank you to our wonderful panelists and the experts that you guys are. And, you know, if you're looking for a program that you really want to emulate, I believe this partnership is definitely, Neighbor Clinic definitely, and Department of Public Health, you definitely want to emulate what they're doing. So thank you all for joining us today. I appreciate it, and see you next time.